Welcome to today's webinar, 3D Radiographic Evaluations, a look into the whole patient. My name is Mike Joyce, and I am the Director of Sales here at Osteoid. I am joined by one of our esteemed in vivo enthusiasts and clinical advocate, Dr. Dania Tamimi. Dr. Tamimi graduated with a dental degree from King Saud University, Riyadh, Saudi Arabia, and trained at Harvard School of Dental Medicine, and where she earned a Doctor of Medical Science and Certificate of Fellowship in Oral and Maxillofacial Radiology in 2005. She is board certified by the American Board of Oral and Maxillofacial Radiology and is a fellow of the Royal College of Physicians and Surgeons. Dr. Tamimi is a reviewer and an editorial board member for oral surgery, oral pathology, oral medicine, and oral radiology, as well as a reviewer for DMFR, oral radiology, head and neck, angle orthodontists, and AJO-DO. She lectures nationally and internationally. Dr. Tamimi is the lead author on 2 textbooks, as well as the co-lead author on diagnostic imaging, oral and maxillofacial. She currently runs her oral and maxillofacial radiology private practice in Orlando, Florida. We here at Osteoid are a pioneer 3D imaging software company who specializes in vivo software, dental services, and our cloud platforms. Originally created in 2004 under the company name Anatomage, our in vivo products and services have continued to be the industry standard in the 3D digital dentistry community. As your co-host today, we are excited to dive into our agenda. First, we will be using CBCT information radiographically. Then we will be going through the details of our anatomy and its multiple interacting systems. And then we will be identifying clues in patient morphology. Before getting started, there are a few housekeeping notes to mention. We will have everyone muted during today's session. Feel free to jot down any questions you have in the Q&A box. Also, we will save some time at the end to answer any questions you have. And for any questions that we miss, feel free to send them to info@osteoidinc.com. Now, without further delay, I will minimize my screen and pass things on to Dr. Tamimi.
Hello, everybody. Happy Friday. I hope everyone's doing well. I don't know where you are in the world. I'm in Florida. It's kind of chilly here, about 65 degrees. Haha. I'm very pleased to be here with you today. I'm very pleased to be presenting this for in vivo. I've been using the in vivo software for several years, and it really is my software of choice. Of course, there are multiple softwares out there, and if you're going to be doing this kind of work where you're going through Cone Beam CTs, you have to have a really good software. You have to have the Lamborghini of softwares, and I believe in vivo is definitely one of those higher tier software. Okay, so they're not paying me to say this. I'm just saying it because I believe this. All right, so what we're going to be doing today is basically we're going to be going through some scans. But before we do that, I'd like to talk to you a little bit about the human body, right? So some of you already know this about me. You know, in addition to being a dentist and a radiologist, I'm also a fitness instructor, yoga instructor, and Pilates instructor. So I have an interest in how the body is put together, how it works, how it functions, how it falls into dysfunction, the human biomechanics, and all that. So when I look at a scan, when I look at a Cone Beam CT scan, I'm looking for multiple clues in how the patient, is underneath their skin, basically. What is their facial skeleton telling me, other than when I'm looking for pathology, when I'm looking for abnormalities? What are the bones telling me? Okay, because every single one of us has a chronicle to their lives, and that is in their bodies and how their bodies appear. The way that you look, the way that you carry yourself, the way that you move, your profession, your multiple ways of interacting with the world around you, what you eat, all that changes the morphology of your body. Okay, most of us as dentists, who are in clinical practice, we have issues with our neck because we're craning our neck and turning over to one side while we're drilling and filling and whatever. No matter how much we try to be ergonomic, we're always a little bit off, okay, because of that preferential rotation in our bodies, okay. And for me as a radiologist, because I sit all the time, unfortunately, at my computer screen, and most of us are in this position, whether we're radiologists or not, we've become a very forward moving society, meaning that we have a tendency to hunch forward or to move in the forward direction, whether it's while we're driving or we're typing or we're looking at our phones, darned phones that are going to mess up everyone's necks, right? And the patterns of motion, the patterns of movement, and the patterns that we adapt to are going to change the morphology of our bones. Okay, so our bones are basically, as we all know, they're alive. We tend to think of them as hard tissue, but really, when you look at an image, a radiographic image, whether that is cone beam CT or plain film, you notice how the outside of the bone is a nice white border and the inside is actually more gray. Okay, so that white border, okay, that radiopaque border or that high density border is mineralized, highly mineralized bone. But the structure inside of that cortex, okay, inside of that border, which is called the cortex, is the medullary bone. And the medullary bone is full of fluid, it's full of life, it's full of fat, it's full of spongy material, okay? And that basically changes our perception when we really think about bone. It's not hard tissue as like a piece of metal or a piece of chalk. There's a lot of life inside these medullary spaces, okay? So now, my fellow radiologists, because I know some of you are here with me, when you look at a scan, try to think of that life ebbing inside that person's bones, okay, as opposed to thinking of these as purely hard tissues, okay. So the bones are going to continuously model and remodel through life. They are not going to stay the same. All of us know this, of course. When you're growing, there are factors that are going to change the way that your skeleton appears. And especially those of you who are orthodontists, that there are changes in the face that follow certain patterns, such as mouth breathing or patterns of dysfunction of the temporomandibular joint or other airway patterns. All these change the growth of that bone, okay, the modeling of that bone. But then once we reach adulthood and we get to a point where there is no more growth, there is now homeostasis, right? There is a balance that's being played here between the osteoclasts and the osteoblasts. And the osteoclasts, as you know, eat the bone away, and the osteoblasts build the bone. So they put bone there, right? So throughout your life, there's going to be that balance. And according to how you move, according to how you sit, according to how you function, the pressure that you put on those bones, there's going to be that remodeling, that subtraction of bone on one side and addition of bone on the other side to change and adapt the shape of the bones to help suit the current function. Okay. So that's something that, like, a little background information about what we're going to be talking about, or how I basically look at cone beam CTs, because traditionally, when you think about what a radiologist does in the medical field or even in the dental field, most of us are looking for pathology. All right, we're looking at the anatomy, we're looking for an abnormality, and if we find the abnormality, we're going to classify it. We're going to look at it and we're going to say, okay, is this normal or abnormal? Could it be an anomaly or pathology? Is it benign? Is it malignant? That kind of thing. That's the thought process that we're all trying to look at. But the thing is that being a radiologist enables you to see things that your fellow clinicians don't. And that is to be able to actually, like I said, peel away the skin and look underneath the skin and appreciate the morphology and the underlying processes that have created that morphology. Okay. So now I'm going to open up some scans. All right. And I wanted to give you that little introduction just so that you see where I'm going with my thought process. Okay. Actually, before I do that, I'm going to introduce you to my friend here. Okay. Actually, I have two of them. One is a magnetic skull. This one's amazing for anatomy, and this one just helps with visualization of the cervical spine and all the structures coming out of it. Okay. So when you are functioning, okay, when you're normally functioning and there's balance in the muscles of mastication and the cervical muscles and everything, the bones pretty much stay relatively similar, okay, to how they were in the past. But once there is a dysfunction, once there is a change in the way that, for example, you bite, or the way that you chew, or the way that you hold your head, that is going to exert pressure on the bones, and that's going to change their morphology. Okay, so I'm going to give an example. So if we have a patient who is still growing, right? So this person, obviously, this is an adult or a plastic skull simulating an adult. Okay, so if we have somebody who's still growing, okay, and that person develops a condition in the temporomandibular joints, which is, by the way, the growth site for the mandible. Okay, if that condition, that dysfunction, alters that growth site, alters the fibrocartilaginous cap that's on top of the condyle, it's going to decrease the growth potential of that condyle as well as the growth potential of the mandible. So instead of having this beautiful normal mesofacial appearance, okay, you'll have issues with the growth of the condyle, growth of the mandible, so the mandible rotates backwards. Okay, so when this mandible rotates backwards or grows small, it's going to change a lot of the soft tissues in this area. Okay, first of all, the thing that lives inside the oral cavity, the tongue, is not going to have as much space anymore, and it's going to also be crammed out of that oral cavity backwards, or the patient may develop a tongue thrust habit, in order to try to take that tongue out of the oral pharynx. And also because the tongue is attached to the mandible on the mylohyoid and the geniohyoid muscles, okay, to the mandible. The mandible, as it rotates backwards, it takes that floor of the mouth and the tongue downwards through into the oropharynx. Okay, so that narrows the oropharyngeal dimensions. Okay, so we have an oropharynx here, all right, which is a tube, and that tube is collapsible, and we've got all the soft tissue around it. Okay, if this mandible rotates backwards and it minimizes the space that you have here, then what's going to end up happening is the patient is going to try to do things to increase airway dimensions. So one of them, I mentioned one of them previously, one of them would be a tongue thrust to try to take the tongue out of the airway, okay? And another one could be an acquired anterior repositioning of the mandible. So when we move our mandible forward, we also take the tongue forward because of all the attachments of the tongue to the mandible moving forward, okay? And also another thing that we're going to do is we're going to move that spine also, because the oropharyngeal tube sits here, okay? And if we all try this, everybody try this at home, sit up tall right now, okay? And just try to breathe in and out through your nose. Okay, so breathe in and out through your nose in your natural head posture. And now I'd like you to move your head forward, okay? And inhale and exhale, and notice how the breath feels in your throat. And then move your head back, keep your eyes level to the horizon, and just notice how your breath feels in your throat. Okay, so just cram your head back. So notice how you can manipulate your airway dimensions just by changing your head posture. Okay, so when a child or an adult has a narrow airway, they're going to move their head forward to increase airway dimensions. And that's going to change the alignment of the spine. That's going to either create an increased lordosis of the cervical spine or a straightening and of the spine, but it's going to be more anteriorly positioned. The head's going to be more anteriorly positioned with more cranial extension. Okay. All right. So that's the background information. Now let's take a look at a case. All right. So let me open it up right here. And all right. So here's the software that I use. let me just minimize all these gray things over here. And where is it? Why isn't it going? Hide video panel. There we go. And hide floating meeting controls. All right, so perfect. Okay, so now this is I think the version of NVivo that is right before this, the most current version. This is the version that I currently have. I need to update it. All right, so a couple of things that we need to be all aware of is that when the Cone Beam CT is displayed on this software, it's going to be displayed in these three planes, right? And these three planes, this is the multiplanar reformat. Okay, so the multiplanar reformat is the axial, the coronal, and the sagittal. All right, the axial is as if the patient is a loaf of bread and you're cutting them up to make sandwiches. The coronal is along the coronal suture, and the sagittal is along the sagittal suture, okay, and parallel to that. And as you can see here, we have these intersecting lines, okay? So each one of these lines represents one of these planes. So if I move the blue line here, this corresponds to the coronal plane. You can see the coronal moving as I do that. This is the sagittal. As I move this right and left, you can see how that is going to change the sagittal position, slicing. And then here's the axial. As we go up and down, we can see how it moves through. We can move through this, the axial slices, okay? And we also have this place where the two lines intersect. And let's say, for example, you're going through a scan and you're like, oh, what is this thing? Okay, so you can take that intersection here and put it at that piece of anatomy and then visualize it in all three planes. And that makes things just a lot easier for you to look at, okay? All right, I'm not going to talk too much about all the functionalities here. I just want to give you some general information here about how to go through the scan to figure out what the story of the patient is, how to look at the whole patient, okay? I just needed to give you that information about how to, all these different planes. And also one other thing is when you open up a scan, the most important thing that you're going to do is you're going to look up here to make sure that the scan belongs to the patient. Okay, so make sure that the name of the patient is the name of the patient that you're looking at, and make sure that the date of birth and the date of acquisition are all accurate, okay? Because you don't want to do any kind of mistakes in terms of, mistaken identity and misdiagnosis of a patient who doesn't have what the scan has, right? Okay, so here is the first thing is you're going to look at this. You're going to make sure that the patient's name and date of birth is accurate. The second thing you're going to do is you're going to orient your scan, okay? And the reason you need to do this is that when a patient is placed in the Cone Beam CT, they may not be lined up perfectly anatomically. Some of patients have issues with their necks. They've got rotations in their C1 that create a little bit of a tilting or a canting in their head. They can have other issues, degenerative joint disease, that don't allow them to fully sit in that position where all of the anatomy is lined up well. And the thing is, the first and most important thing that you need to do with the scan when it comes to the diagnosis is you need to make sure that there's no pathology, okay? So when you're opening up a scan, there are two parts of your brain. There's the part that is your radiologist brain and the part that is your dentist brain. And the part that is the radiologist brain is what's going to be going through the scan to make sure that there is no pathology. And in order to do that, you need to line up the scan or reorient it in a way that enables you to look at both sides of the scan symmetrically so that you don't miss anything. Okay, so the first thing you're going to do after you look at the number, the name and the date and the date of acquisition, you're going to line up the scan to the external auditory canals. You're going to find these external auditory canals, which are relatively easy to find. It's these black, very thick lines in the head. Pretty much it's where you put the ear rods if you do a ceph, okay? So just think of it that way. I'm trying to line up the head as if I'm doing a lateral ceph or a frontal ceph, okay? So I've got these lines. I'm going to try to make the blue line here touch the back of the external auditory canal. And I can see that I don't see it on this side, right? So I'm going to need to do a little bit of reorientation. And on this software, this is where you find the reorientation button, okay? So if you hover over it, you're going to see reorientation. You click that, okay? And when you click that, then you can start to move your scan a bit so that you can see the two external auditory canals, you can see how this one is a little more forward than this one. So you're going to rotate that slightly as such, okay? And then you're going to do the same thing here for the coronal, where you take the axial and make it touch the bottom of the external auditory canal as such, okay? So you're reorienting the scan so that when you're going through the scan to make sure that there's no pathology, all the anatomy on both sides is appearing at the same level, okay? And that just makes it so much more efficient and quick for you to, and effective too, for you to identify this pathology, okay? So, right, so we've identified the patient, we've reoriented the scan on both the coronal and the sagittal. I make this blue line touch the back of the external auditory canals on the axial, and I make the red line touch the bottom of the external auditory canals on the coronal, okay? So what do I do for the sagittal? I like to line up the heart palate with the axial plane, so ANS to PNS relatively, okay? So I am changing, if this is whatever the patient's position was their natural head posture, then I have to be aware that when I'm doing this reorientation, I am changing that patient's natural head posture or whatever posture that they were in during scan acquisition. But that's important it's important for me to do this reorientation because I need to look for pathology. Okay, that's like the main reason why we acquire cone beam CTs after the diagnosis of the dental thing that we need to make sure that there's nothing on the scan, okay? All right, so like I said, now 2 parts of my brain. There's the thinking like a radiologist, thinking like a dentist, okay? So just for time's sake, I want to go straight to the thinking like a dentist. When I'm done with the thinking like a dentist here, I will show you the thinking like a radiologist, okay? But I just want to show you, because I gave you this whole introduction about how the different parts interact with one another. So I want to make sure that I have enough time to show you that, okay? All right, so now this part is part 2, which is thinking like a dentist. So the first thing I'm going to do is I'm going to create a panoramic radiograph, okay? And the panoramic radiograph, I need to create something that helps me take a broad look at the dentoalveolar complex, just like the panoramics that we normally do. And I would like to make sure that the jaws are in the field of view. So I adjust these. And then I adjust the spline line right here, which is going to be running through the mandible. And there's a little preview right here that kind of gives me an idea where I'm going. If anything is outside of the focal trough, I can adjust that. You can see how I'm lining up these dots with the arc of the mandible, and then I can increase the focal trough just a bit to put more bone inside that focal trough to make it less, to reduce the number of artifacts. As you can see here, if I do this, there's more artifact, and then if I do this, it kind of looks more even. The teeth are there, the bone's all there. Okay. Right, so if I'm happy with this, I'm going to create a pano, which I will, and I just create a pano and I take a look at it. And I take a general view of this. I'm looking at the teeth, I'm looking for any supernumerary teeth, I'm looking for any periapical pathology, I'm looking for any osseous pathology. It's just easy for me to look at the whole thing here in terms of like the jaw pathology, just as we were taught in dental school to look at panoramics, okay? So I start with this. The difference between the panoramics here and the panoramics that we did in dental school is the fact that we can, on these cone beam CT panos, we have the teeth in maximum intercuspation, which is a huge diagnostic plus, okay, when it comes to the whole thinking like a patient of the patient and how the patient is all put together, okay? Because the TMJs and the teeth are connected to one another, okay? And we need to make sure that our condyles are in an orthopedically stable position prior to doing any kind of work, dental work, orthodontic work, whatever, okay? And what does that mean? It means that the condyle should be seated in the fossa. And normally on the 2D pans, we can't do that. We can't bring our patient into maximum intercuspation because of the nature of how the 2D pan is taken. You have to bring both jaws into the focal trough. You have to protrude the mandible in order to bring both jaws into the focal trough so that we can see the bone adequately. So when you do that on a 2D pano, the condyles are going to come down and forward. Okay, that's what you normally would see on a 2D pano. Now on the 3D pano, on the cone beam CT reformation, panoramic reformation, we can see how with the teeth in maximum intercuspation, these condyles are not seated in the fossa, they're down and forward. And that gives us a diagnostic clue to the orthopedic stability of this patient's occlusion. Now, I want to take a step back and say that the orthopedic stability of the occlusion is actually something that you detect clinically or you diagnose fully clinically, but there are clues to it here on our cone beam CTs. And I'm going to show you now, I'm going to create my TMJ cross sections. Okay, so when we come to the TMJ cross sections, we're coming to the axial plane and we're going to be creating cross sections. They're called axially corrected cross sections in the sagittal and coronal oblique views to visualize the true anterior posterior dimension of the condyle as well as the true mediolateral dimension of the condyle and its relationship to the fossa. Okay, I'm going to make this just a bit bigger. I'm zooming in here by pressing Control and left mouse forward. For those who are PC users, I'm not 100% sure what it is on Mac. I think it's Command left mouse drag forward. Okay, so now I don't know why this is happening. Okay, so now we're going to take a look at these. I'm going to get rid of all the lines. It's a good practice to get rid of the lines when you're trying to diagnose a patient's scan, so you don't obscure the anatomy. Okay, so we're looking at the anatomy here. Okay, so I want to talk about what constitutes normal in terms of a TMJ. Okay, normal TMJs have a little bit of a bend forward like this. There's a posterior height of contour and there's an anterior height of contour. And these two are not at the same level when the condyle is normal. Okay, it just reflects, this bending reflects the pattern of growth of the condyle. When you're born, you've got a little stump, and then the fibrocartilage is put down in this direction, or the bone is put down in this direction by the fibrocartilage, and then the mandible rotates forward. And in that favorable growth pattern because of that pattern of growth. So when you have a problem with the condyles in terms of it becoming degenerated, then these heights of contour come closer together. This one rises up and there's a remodeling that occurs. Okay, so now that's just a side note. Now the normal condyles, posterior height of contour is lower than the anterior height of contour, and this surface should be rounded. And we can see how there's a little bit of a flattening of this articular surface, which tells you something. Remember how I said bone is alive? The bone tells you stories, and you have to know how to read the language of the bones, and you need to have an understanding of what the bone means when it puts down more bone. It's telling you something. It's telling you that there is excess force on that surface, okay? Normally, this cortex is eggshell thin, all right? And to have it thicken like this is telling you something about the amount of forces that are being placed on this. So the flattening is also a sign that there's more forces. When you see a flattening or a thickening, that's telling you that the patient's bone, that articular surface, is trying to increase surface area by flattening it out. And then also it's buttressing the bone and putting down more bone to protect the surface from breaking down. Okay, so these are called functional remodeling, and it's a sign that there is something biomechanically amiss in this TMJ. There's excess loading. Okay, but now back to the orthopedic stability thing. Look at how the condyles are like inferiorly positioned in the fossa. This is way big right here and right here. Normally, when we look at the TMJs on cone beam CT, we cannot see the disc. There's no way you can see the disc on cone beam CT, but the proportions of the space here should tell you something. Okay, there should be like enough space for a little bow tie in this area. And the height of maximum curvature here should be against the height of maximum curvature here. And we can see how the condyle is down. And this space, which is supposed to house the posterior band of the disc, is widened, and it's widened bilaterally. And when we look at the coronal, we can also see how the condyles are moving outwards. Okay, and that's what happens when you open your mouth. There is a little bit more of a lateral repositioning of those condyles as they approximate the lateral rim of the fossa, which is why many of our degenerative joint diseases and disc displacements occur off of that lateral aspect, because that's the area that thins the first in the opening process. Okay. All right, so these condyles are not seated in the fossa. The teeth are in maximum intercuspation. The condyles are not seated in the fossa. This tells me that this is not an orthopedically stable situation and that there is functional remodeling because of excess loading. All right, so now let's move on to the next set of images. We're going to create a volume rendering. Okay, so when we create a volume rendering, we're looking at the facial skeleton, right? And we can see how there are a couple of things here that are interesting. We see how narrow the arches are and how narrow the mandible is. Okay, normally the ramus of the mandible is relatively vertical, and we can see how narrow it all is. Okay, and if I create this bone view, we can also see some periodontal bone loss. So this is a surface rendering showing us the surface of the bone, and we can see this exostosis, right? So exostosis all the way around. Okay, and this exostosis is also telling us a story. Remember, the bone is telling you stories. And the exostosis, like this in the cervical margin of the teeth, tells you the story of excess force. The bone is responding to excess force, to bruxism. Okay, so this alveolar process exostosis is a sign of bruxism. Okay, increased forces, occlusal forces on that bone. All right, so now the volume rendering, so that is the frontal view. I'm going to do the side view, and in the side view, I like to make sure that the two zygoma are superimposed over each other, and I look at the morphology and the symmetry of the mandible when I do that. Okay, so we see a teeny bit of asymmetry. It's really nothing to write home about. It could be positional as well. One side may be a little bit more inferiorly positioned than the other. We tend to see these asymmetries also when there's a unilateral condylar height loss, like for example, if there's a progressive condylar resorption, otherwise known as idiopathic condylar resorption, or if there is a juvenile idiopathic arthritis or a trauma or whatever it is, so the asymmetry on this view is going to tell us, is going to manifest, or we're going to see a double line here. We're going to see the inferior border of the mandible and the angle of the mandible also being two different levels on both sides. All right, so when we look at this patient's profile, okay, and we look at the mandible and we look at the teeth and how they fit together and all that, you may think to yourself, oh, okay, so this patient is a class 1. Look, all this canine class 1, molar class 1, facial profile looks relatively straight. But now when you take a step back and you look at the TMJs and the fact that the condyles are downwards and a little bit forward in the fossa, does that change what you think? Does that change where you place that mandible? And if the mandible was seated in the fossa, if the condyle basically were seated in the fossa rather, what's going to happen to the mandible? It's probably going to rotate backwards. It's probably going to be repositioned backwards, and that's going to manifest as a class 2. All right, so the position of the mandible forward and the teeth coming into that occlusion, they may have been put there by an orthodontist. Maybe that's how the teeth super erupted with that forward mandibular posture. This is a sign of a dual bite. All right, so dual bite is where you have a CRCO shift. Okay, it's an orthopedically unstable situation where you've got one bite in maximum intercuspation and another bite when the condyles are seated in the fossa. Most likely, if you take these condyles and put them in the fossa, you're going to end up with an open bite here and a posterior rotation of the mandible. All right, so it's a dual bite. And if you're not careful in diagnosing this and you proceed with your dental treatment, whether it's orthodontics or full mouth reconstruction or restorative or whatever, then what's going to end up happening is a few years down the line, the condyles will seat eventually into the fossa and you will end up with an open bite anteriorly. Okay, so it's important to diagnose condylar seating prior to starting your treatment. Okay, but there's more to the story here. There's more to the story. So we've looked, there are a couple of things that said bruxism, right? There's the flattening of the condyles, the thickening of the cortex, and the alveolar process exostosis. And we also looked at the presence of a dual bite. We've identified that, but we have to look at some more things. So let's take a look at the cervical spine here. Okay, and maybe if I do this view right here, you'll appreciate just how forward neck is. Okay, and you have to look at enough necks, cervical spines to appreciate really what normal neutral cervical lordosis looks like. But this is a forward head posture, okay? And this forward head posture may be because the chin is being placed on a chin rest. So you always have to make sure to correlate what the patient's natural head posture is to the posture with the chin, in the cone beam CT before you make any judgment about where the neck is or also where the airway is. So remember how I said in the beginning, your tube, this tube right here is malleable and it's going to change with head posture. So if you're scanning a patient and you're using a chin cup or some device that's moving the head forward, that's going to increase airway dimensions. So you have to be careful not to misinterpret whatever dimensions you have here as whatever their normal dimensions would be in natural head posture, because as I demonstrated or had you guys do before, if you move your head forward, you increase airway dimensions. If you move your head back, you decrease air dimensions. Some cone beam CTs ask you to put the patient's head back against the headrest and Velcro their forehead back, and that's going to decrease airway dimensions. So just be aware of that pitfall. So let's take a look and see how narrow this airway is. Okay, and normally I go down to the level of the hyoid, but the hyoid isn't here, and the program, if we try to start the volume from down here, it won't register it. So I just stay safe from and stay away from the bottom of the scan when I do this. And then you can see how the airway dimensions are narrow. Now I'm going to say something, and I have no shame saying this at all. I don't really put much weight on these volumetric measurements. And it's not just the software, but all softwares, okay? Because there are so many variables, okay, and so many pitfalls that can affect what these dimensions are. One of them would be, where I put my dots, right? Another one would be the thresholding, okay? So the thresholding right here, when you threshold something, you're basically telling the software, hey, I want you to pick up everything that is, this density right here. I want you to identify it as airway. And the software will pick up all these little voxels that are of the same density, of the same Held-Field units or grayscale unit, and it's going to identify it as that. But the thing is that if you don't threshold this properly, okay, you may pick up soft tissue in this. So I'm just going to demonstrate that. So you see, I've changed the threshold and now it's picked up some of the soft tissue and identified it as airway. So be very careful, okay? And I really do appreciate that Invivo has this ability to change the thresholding, because then you can look at the anatomy and you can make sure that the airway volume is adapted well to the actual outlines of the lumina of the oropharynx. Okay, so so in any case, it's a very narrow airway. All right, and this very narrow airway is there are multiple things that can play into this narrow oropharyngeal airway. One of them would be large palatine tonsils. Okay, so we can take a look here. Actually, let me go back here and look at the coronal view to try to see if there's any palatine tonsils. Now you're going to be like, oh, what's going on here? I can't really see the whole oropharynx. Well, look what you can do here with the cone beam CT. You can adjust this, you can rotate it so that your coronal view runs through the actual airway, okay? And when you look here, you see a narrowing of the oropharyngeal airway, but it's not like this fungating lobular appearance that you see with palatine tonsils. Many times the narrowing that happens, especially in overweight adults, happens because of parapharyngeal fat accumulation, okay? So that's that. So we go back here and readjust that. All right, so going back to this, all right, so another thing that can narrow the oropharyngeal dimensions is the size, the length and the thickness of the soft palate, all right? So the soft palate starts here and it ends at the tip of the uvula down here. And sometimes it's hard for you to see how thick the uvula is or how thick the soft palate is, you have to look for a little air interface, which is this right here. And on this software, you can create a curvilinear reconstruction. If you're using another software, you can do several straight lines and then just do some simple math. This one just makes it easy for you to get a curvilinear measurement of how how long that soft palate is. And this is pretty long. Usually the cutoff for this is about 39 millimeters. All right. And then you try to see that interface. If you can find the air interface, you go from there to there, and you can see how thick the soft palate is as well. The soft palate thickness shouldn't be more than 9 millimeters. This is about 10. Okay. And when a soft palate is thick, that's usually either because it has edema. With snoring, you can get edematous soft palates in the uvula. You can get fibrosis. You can get fat accumulation there as well. Okay. All right. So the oropharyngeal dimensions may be narrowed because of the soft palate length and uvula thickness as well as the dimensions of the oropharynx laterally, the medial-lateral dimensions, possibly because of fat depositions or something like that. Okay, all right, so we do have a little torus here as well. We'll look at that in just a moment, okay? So this right here is one of the reasons why this oropharynx is narrow, the narrow oropharyngeal dimensions. So this kind of, now when you see this and you say to yourself, okay, this patient's head posture is forward, yet the oropharyngeal dimensions are still small. Then you're like, okay, so what would happen if this patient actually came into their natural head posture, or if their natural head posture was different from this? How much smaller would the oropharyngeal dimensions be? They would be pretty small. Okay. So one way to figure out if this is natural head posture or not, is of course examining your patient clinically. But now for my radiologist buddies who are in the room, who we don't really see people in our practice, we see these black and white images. One of the ways that you can try to determine this is, of course, look for the chin rest, but also look at the cervical spine, because remember how I said bone is alive and bone is responding to alterations in posture and position. So when we're going through the cervical spine, we're trying to see if we can see any kind of degenerative changes in the cervical spine, an approximation of those spinous processes or lateral processes. The spinous processes are back here. These are the lateral processes with little osteophytic changes. See this one particular, you can see how the intervertebral foramina are narrowed, and there is sclerosis, and there is all this osteophytic changes. So yeah, so there are degenerative joint disease changes to the cervical spine. Okay, so that leads me to think that there is some kind of postural issue with this patient that has caused this imbalance that has resulted in this osseous change. Okay, all right, so with all that said, let's go back to this. All right, so we're going to go back to the MPR, and I want to take a look at the transverse dimension of the arches. Okay, so I'm coming over here to this level, the level of the first molars. And if we're going to follow McNamara's analysis, we need about 36 millimeters between the CEJs of the first molars. This patient has about 33 millimeters approximately. There's a little torus here. Those here are the little alveolar process exhaustoses. Here are tori as well. Now, we've all been taught that tori have a genetic predisposition to certain populations, but they can also be a process of flexion extension in the bone, also with excess loading. Okay, along the suture, there can be a proliferation of the bone in that area, creating this appearance. Okay. So now that we have also the transverse dimension of the nasal cavity is narrow, as you can see. And yeah, so we're looking at all this. Now, the transverse dimension of the face is narrow. The transverse dimension of the arches is narrow. So how do you think that this could have happened? Well, I mean, some people just have bad luck of the draw, but I do believe that, when a patient has issues with their growth, with their breathing, with their tongue posture, if their tongue isn't always up to the roof of their palate, then there is going to be a sequential change in the transverse dimension of the arches because of the buccinator muscles pushing against the alveolar processes, narrowing that. Okay. All right. So let's try to put the story of this patient together. Okay. So we're going to put the story of the patient together. We've identified a dual bite. Let's go back to this. We've identified a dual bite, right? We've identified the airway issue. We've identified all this bruxism and all that stuff, right? All these changes that are indicative of excess loading. Okay, and of course, remember, I'm a radiologist. I don't get to see the clinician, the patients clinically. Okay, so you, as a clinician, if you are a clinician out there, you're going to take my report, you're going to take my finding and correlate that to the patient's history and clinical presentation. All right. So when we look at this patient, all right, the things that we are assuming that have occurred with this patient are the following. The patient has a narrow airway. Okay, for whatever reason, the patient has a narrow airway, and that narrow airway is going to elicit a response in that patient to stay alive, to breathe, okay, to increase airway dimensions. And the two things that we can see here that the patient has done is move the mandible forward, okay, slightly, and then also move the neck forward, okay, and in both of those are going to increase airway dimensions. All right, and of course, because of moving the head forward, moving the mandible forward, the condyle has moved forward into the fossa. The teeth are in maximum intercuspation. They've super erupted. The condyles are not seated in the fossa. Okay, with the neck forward, now we have degenerative changes that have occurred to the cervical spine. And the bruxism, I mean, the bruxism could be and of course, this is something that you will also evaluate clinically. These findings right here, these alveolar process exostoses, as well as the flattening and all that, you need to correlate that to the clinical presentation. Does the patient have stress in their lives? Does they have awake bruxism? Is it sleep bruxism? Okay, because the sleep bruxism would fit the story very well of a narrow airway, right? And then, of course, you send them off to a sleep study and you try to figure out, whether they do have sleep disordered breathing or not. And then you base your treatment plan on the results of that test, as well as where the condyle, where that occlusion is going to be when the condyle is seated in the fossa. Okay. All right. So that's the story of this patient. I thought I spent a little bit more time on this patient than I would have liked to. But I'm going to just quickly show you another patient, and I'm just going to create the volume rendering for this patient in the TMJ views so I can show you this story in the few minutes that are left. Okay, so this patient right here, if I turn it to the side, you can see very clearly we have a patient who has a small mandible, a posteriorly rotated mandible, and an anterior open bite. Okay. When we turn this patient forward, we can see the narrowness of the arches. If you don't believe me, you can come over here and test it with McNamara's number, which is over here on the first molars, and go from here to here. Okay. And it is a narrow arch. And this patient at the time of acquisition was about 17. So that person should have already had their full adult morphology. Okay, so when we look at this patient's morphology, the 3D imaging, the 3D evaluation of that patient's skeleton, and we correlate that to the occlusion, and we correlate that to the TMJs, which I'm about to show you right now. And remember what I said about the heights of contour? I'm about to show you a case where the heights of contour are not at the same level. Okay, so here we have a patient whose posterior height of contour is higher than the inferior height of contour on both sides, and the condyles are small. And when you see this kind of a configuration of the heights of contour, you know that this is a case of previous destruction of the condyle that has remodeled. And in this case, it was idiopathic condylar resorption. So degenerative joint disease in a young individual that has reduced the volume of the condyle, and then now it's remodeled. Okay, it's remodeled, and the condyles, after they have been reduced, have seeded into the fossa. And when they seeded into the fossa, they opened up the bite and took the mandible back. So as the mandible rotates backwards, the bite opens up anteriorly. Okay. All right. So yeah, so that was a that was a very quick overview of this. So remember what I said previously, the first part of reading the scan is thinking like a radiologist, and we didn't do that part, which is going through the scan for pathology. But I wanted to focus in on looking at the whole patient, looking at the different moving parts, the TMJ, the airway, the occlusion, the cervical spine, and how it all fits together. Okay. And of course, there's more to this patient, but I've run out of time. And I just wanted to make sure that I showed you this example because there are points that I made in the first case with the heights of contour and the rotation that I wanted to make sure that you can get a visual of. All right. So I'm going to stop sharing right here. And we've got about 9 minutes for questions. Let me take a look and see what we have here. Hey, Mike, are you going to ask me the questions, or do I just go ahead and read what's on the?
Yeah, I can ask the first couple ones that came in.
All right.
Does the pan show anterior and inferior displacement of the condyle?
If the teeth are okay, normally on a 2D pan, when you have a 2D pan, because of the way that the pan is acquired, you have to have the teeth on a bite stick, right? And when you bring the teeth onto a bite stick, then you protrude the mandible. So the condyles are going to move down and forward. Okay. Now on a regular, on a 3D reformation, on a 3D cone beam CT reformation, panoramic reformation, with the teeth in maximum intercustation, those condyles should not be down and forward. Okay. They should be seated in the fossa. Okay. And I see the other question also Lester was asking, the size of the condyles are incompatible with the size of the fossa. That happens, that you can have a remodeling of the fossa. Remember how I said the bone is alive and it's constantly changing? Okay. When you create a vacuum in the fossa, sometimes you'll have a situation where there's addition of bone, like an osteoneogenesis or a progressive remodeling that occurs. Okay. And this happens a lot. We see it a lot with disc displacements. We see it as an extra layer of bone on the roof of the fossa sometimes. Okay. So if you use a bone in a certain way, it's going to remodel in a certain way. And if you don't use it in a certain way, then it's going to atrophy. That's Wolff's law, right? Okay. If I take my finger and I press it against my mandible and I hold it there for 3 months, I'm going to have a concavity because my osteoclasts are going to wear away that bone. Okay. If you look at the mandible and all the ridges and all the different parts, everything in the mandible, the anatomy, even the coronoid process, let's use the coronoid process as an example. The shape of the coronoid process and the elongation of the coronoid process is thought to be a process, a result of the pull of the temporalis muscle upwards. Okay. The lingula, the that's on the inside of the mandible, where you have the anterior border of the mandibular foramen. You have the sphenomandibular ligament pulling on that, right? So every groove, every bump has something attached to it. Every groove has something pushing against it, right? All right, let me see who else. Yeah, I see a lot of friends here. Oh, merci. Let's see who else. What views are better to see the zygomatic bone fracture? Okay, so that you can use a cone beam CT to see that. That's easy. But if you're still in 2D world, okay, you're going to do the submento vertex view, okay, which is basically you have the patient place their head against the film, the cassette like that, and then direct the beam through the zygomatic, like directly down through the vertex, so that you can see the zygomatic arches. Okay. All right. Should we take the cone beam CT and CR or CO? Okay. I would have you bring the patient into their bite. Okay. Centric occlusion. Okay. Because that's going to reveal a lot of things. It's going to reveal a lot of things about the condylar position in relation to the occlusion. There are so many different differential diagnoses for condylar position, for posterior condylar position, superior condylar position, inferior condylar position. And when you have the teeth in maximum intercustation, you can very easily make out what that position is when the patient is in the bite that they're presenting in clinically. Okay, because CR, if you're going to be manipulating the patient into CR, you're putting them in something that is not where they normally hold themselves. Okay, so you're not going to be able to really look for those anomalies or abnormalities. Okay. And I have to say, the soft tissues you cannot see the soft tissues. You can't see the disc. You can't see if there's a joint effusion. That's where you enlist an MRI. Okay. If you want to take a look at the disc and see where it is, that's you can't do that with cone beam CT. Okay. So how can you differentiate between true positional asymmetries of bone and fossa as opposed to just rotated head posture position during cone beam CT acquisition? Okay, so oh my gosh, this is one of my favorite questions to answer. Yay! All right, so here's the thing. Okay, asymmetries can happen anywhere. Okay, so asymmetries can happen anywhere in the head. Okay, you can have an asymmetry in the mandible, and many times that asymmetry in the mandible is a result of the TMJs being asymmetric. And of course, you can have asymmetries in the size of the ramus, asymmetries in the size of the body of the mandible. You can have asymmetric maxilla. You can have an asymmetric skull base because of a sphenoid rotation. Okay, so if I take my skull apart right here, I can show you that. Which is why I love this skull, right? So here is the occiput and here is the sphenoid, right? And sometimes some patients have a little bit of a rotation in their sphenoid like that, and that's going to cause a facial asymmetry. And that's very difficult to see on 2D, all right? And you can detect them on cone beam CT. You can have an asymmetry because of the head posture and also because of subluxation of C1 over C0. Okay, so there are multiple reasons. Now, I find that the easiest way for me to identify if the asymmetry is postural versus skeletal, like skull. Okay, when I say skeletal, I mean like the cranium. Okay, when I'm trying to look for these distortions in the cranial, in this spheno-occipital synchondrosis, rotation, and all that stuff, that's why I use the external auditory canals. I used to use previously, before I knew that there were skull-base asymmetries, I used to use foramen ovale and rotundum and all of skull-base foramina. But I realized that if I use those, I'm not going to be able to see the skull-base rotations because there is ovale right there, those little ovals. If I use that, then I'm not going to be using a proper reference for the evaluation of an actual rotation in that bone, right? So that's why I use the external auditory canals. The way anything can be asymmetric in the head, but the part that is most constant is the position of the external auditory canals, because the temporal bones house the auditory complexes as well as the balance, your cochlea, your semicircular canals, and all that stuff, right? So you have to have that in balance. So you use that, okay, as a reference, and then from there you can very easily see if the sphenoid is off, right? You can easily see if it's the mandible that's off. But if you're using the skull as it is, okay, you can look at that, but it's not going to help you evaluate for those skull-base asymmetries. You can look at what the scan looks like with the patient's natural head posture or whatever posture that they're put in, but it's not going to help you evaluate for those skull-base asymmetries. Okay, and I can talk about this for hours, but I hope I answered that question. Okay, right, so we have here someone was telling me, will the external internal rotation of temporal bones result in the TMJ condylar morphology? That's exactly what I was talking about. So this is osteopathy. You know what, I don't have time to mention this, but if you do want to read more about this, look up cranial osteopathy. Okay, skull-base rotations, cranial strains, that kind of stuff. And I'm not saying that we should be using osteopathy for orthodontics or anything like that. I mean, that's not my world. I'm just the thing that I like about this field that has helped me appreciate the skull base asymmetries that I was not able to classify prior to having that knowledge. Okay. So definitely things will change. Your position of the mandible and the position of the condyle and the position of the fossa, all that changes, and bones are going to respond according to function. But I don't have an answer for you for this particular point. Okay. Like an actual quantitative, this is how much rotation that you need for a TMJ morphology change. Okay. And right. Okay, so good. I think that we are at 1 o'clock.
We
If you want me
are.
to keep on going, I can, but I think you have something to do, right? You guys have something. Everyone has things to do with lunch break and okay.
I did write down the questions, or I was able to jot them down, so we can make sure we respond to all of you individually if we did not respond to your specific question. But we are out of time, but this was amazing. Thank you so much, Dr. Tamimi. Seriously, this was such an awesome presentation. You did a great job.
It's
And
my
we will
pleasure.
be sending out the recording to everyone next week. Please be on the lookout. We will also be including a discount for anyone who's interested in the software. Since you joined the webinar, you'll be eligible for that discount, and that will be in the blast going out next week. So
Right.
awesome.
And if there's anyone there who's looking for a radiologist, we have several oral maxillofacial radiologists here in the country, several companies that read, there's beam readers as well as 3DDX and others, individual radiologists. Look at the universities. I see some of my friends here who are university radiologists as well who read cone beam CTs. So if you need that kind of interpretation, please reach out to them. They'll be able to help you out. Okay.
Fantastic.
All right.
All right. Thanks again. This was amazing. And thank you everyone for joining. Seriously, we really appreciate it. We hope you all have a great weekend.
Thank you. All right. Goodbye, everybody.
Bye now.
Bye.